Welcome back to GLOW 2020. My name's Andrew Weeks, for those of you who are just joining us, and I'm chair of the organising committee locally. Welcome to GLOW 2020 with a focus on implementation research and respectful care. For those of you who are trying to link in earlier, we had some technical difficulties connecting with our outside link to Annie Potella. So those of you who are linking in will have heard us. We extended the discussion with Sally Theobald and her team about how to do implementation research, and we hope you found that useful. For those of you who are coming in on the slightly different link to look for posters with discussion, we showed that a little bit earlier in place of Annie Portella's presentation. That link will be available once we've finished this, so as to enable you to click on it at a later stage. And in fact, all the presentations, as soon as they've been done, will then become available for you to look at a later stage. Now, of course, we couldn't really do a global maternal health conference without talking about COVID. It's affected us all. There's nobody who's been separated from it. It's affected all of our lives in one way or the other. And we're lucky that one of the benefits of doing an online program like this is that we can connect to distant places, usually, so long as the video link works. And respect to the BBC, they clearly, I now have greater appreciation of the sort of things that they go through. But it allows us to connect with really top people around, and we're very lucky to have two fantastic speakers who are joining us. So Ambrose Talasuna, Dr. Talasuna, is working in WHO Africa office in Brazzaville in the Congo. He did his medical training originally in Uganda and then postgraduate training in epidemiology and public health in Antwerp, London and the USA. In fact, he and I met when I was working in Uganda in 2001. I think when Ambrose was head of epidemiology at Ministry of Health, but from then on he's continued to rise through the ranks and has taken up senior positions in malaria control in Nairobi, Oxford, and now is in the WHO Africa office in Brazzaville. In fact, he's speaking to us from Pretoria, where he's working on the COVID response. The other person who we've got is Dr. Rajiv Tajadeen, known as Taj. Originally trained in pediatrics in public health, and in fact, when you read through his CV, it looks like a who's who of places to study. He's got qualifications from Nigeria, South Africa, UK, including here at the Liverpool School of Tropical Medicine, India, China, and the USA. And he's currently head of Public Health Institutes and Research at CDC Africa. And he's heading up the healthcare preparedness and countermeasures for their COVID response. So first of all, we'll go across to Ambrose Talasuna in Pretoria from WHO. Ambrose, are you there? I'm hoping that he'll be able to link to us and he can hear us. Ambrose, can you talk to us about the non-COVID effects of the pandemic?
Thank you very much, Andrew, for that introduction, and good morning, good afternoon, good evening, wherever you may be. These are very challenging times, and I would just like to talk to you this morning or this afternoon about the non-COVID effects of the pandemic. And if I can move these slides. I can't move the slides, Andrew. You might have to move for me the slides from there, Andrew, because I can't move them from here. Okay. In terms of as an introduction, really, in Africa, the COVID-19 outbreak is slower than what we had predicted, even if we think that we are underreporting, but also critical cases are fewer. But we are seeing that in some countries, they're really already, the systems are already overstretched, and because of demand, and there is also low inherent resilience, and I'll be coming back to that in a few minutes. When we draw lessons from the 2013-2016 West Africa Ebola epidemic, the death caused by disruption of essential maternal, newborn, and child health care services, and also programs like for measles control, for malaria, HIV, and tuberculosis, far exceeded the direct effects from Ebola. And so the real things that COVID, the disruption is really very important, and we need to be tracking that. It has been projected that a 15% reduction in maternal, neonatal, and child health coverage during COVID for about 6 months could result into over 250,000 additional child deaths and maybe over 12,000 additional maternal deaths in low-income countries. And so this is really worrisome for us. And in terms of affecting continuity of the health essential services, I think COVID is affecting across all the critical health performance pillars, as we know them, the four performance pillars of the health system. It's affecting access, and really people in terms of physical access, because there are barriers, there are movement restrictions, so physical access has been affected. But critically also financial access, because people have lost income just because in low socioeconomic status, I mean, informal sector, people have lost jobs. So COVID has disrupted that as well. Quality of health services in terms of has been affected. Demand, because people can't be able to visit the services because some of them are closed. And then a critical piece of it is also resilience. Well, let me just go back to a bit of talk about resilience. And this is really what does resilience entail? And in pre-outbreak, you need to have routine services. But when then there is a crisis, the services should be ramped up and should be able to deliver both routine services and also deal with the crisis. But when systems are not resilient, then you don't have that, what we call the resilient dividend. So continuity of essential services is disrupted. And we've been struggling this across the board. We try to build international health regulations, health capacities, as we also build resilient health systems in terms of delivering universal health coverage. But at the moment, really, we are finding that on the continent, there are problems and challenges in terms of health systems, but also in terms of the IHR core capacities. We've been trying to monitor indicators, and several of the indicators that could track to help us to see whether a continuity of health services has been affected. And we've been looking at things like outpatient utilization per capita, inpatient utilization, bed occupancy rates, and also childhood immunization. And we have some data, a dashboard, and I will link you to that dashboard there. You could get the data that we have on that dashboard. But what we are saying is that OPD utilization and inpatient visits have dropped in 2020 compared to 2019 and 2018. Child immunizations have dropped, and in some scenarios, we are seeing outbreaks of measles because kids are not getting immunized. And the number of people accessing their TB drugs or their antiretroviral therapy has also dropped. So some countries like Namibia have looked at putting in mechanisms of door-to-door delivery of these services. But if you don't then do that, we will see that we might have excess mortality because the indirect causes of COVID are also very, very severe. And we've monitored some indicators working in what we call the Partnership for Evidence-Based Response to COVID, which is a partnership with Africa CDC, Resolve to Save Lives, Ipsos, London School of Hygiene and Tropical Medicine and Economic Forum, and WHO. We've been tracking some of these things, and we've carried out surveys periodically. And I'm going just to give you a snapshot of some of the data. The methodology we use is that we do surveys. Ipsos is mainly the one doing the surveys. So I'm just going to give you data from the August poll, which was conducted by Ipsos in 18 African Union countries. And samples were drawn from nationally representative member states, and we weight the data. So if you look at missed or delayed health services, 44% of the respondents say they had missed or in somebody in their household had the delayed healthcare service. And some of the reported disruptions were most common if there was a COVID-19 patient in that household, if respondents had a long-standing illness, or if respondents were living in urban areas. But surprisingly, with respondents with mental illness. So you can see people are missing their services, or they're having their services which are delayed. The reasons for the missed services are several, depending on the country, but if you look at the chart, couldn't afford it, largely because of cost. People have lost jobs. Facilities have been closed. In some scenarios, facilities have been closed. Facilities have been too busy. People are responding only to COVID, but also you can't get to the health facilities because of the lockdown or curfew. So you can see the reasons are varied, and these disruptions are really affecting the indirect causes of COVID. The types of meat services are also variable depending on the country. If you look at a country like Nigeria with the burden of malaria, 37% of the respondents had delays in visits for malaria. And so there are also combined disruptions in maternal and newborn and child care across several countries. So you can see in those charts, actually maternal and child health services are being disrupted. And so we need to be tracking maternal death, infant mortality, and under 5 childhood death. In terms of difficulty in accessing medication, you can also see, it's more than 1/4 of the respondents reported difficulty in accessing medication. Others reported missed or delayed services, highlighting which is high among the income respondent. In Sudan, for example, almost 2/3 of the respondents reported difficulty in accessing medication. And this is really, really worrying. In contrast, in Senegal, this accessing medication is slightly lower, but you can see it's also varied. And so we need to be tracking all this. And this is why we need to be triangulating data from different sources to look at how indirect causes of COVID are affecting the populations out there. And I think that's why we've been saying we need to have a balanced way of implementing these public health measures. I think this is my second last slide. If you look at the impact on economic and food security, a majority of the polls have said people have experienced barriers to purchasing food. So I think we can have lockdown, but lockdowns cannot continue for all the time. So you can see food insecurity is taking place. So people, if we don't relax measures, in some of these countries, people are not going to access even food. And then look at expectation. We also did on what expectation of people in terms of the trade-off between relaxing measures and the data are variable. So loosening restrictions, of course, people think that it is too risky to loosen restrictions versus there is a low risk and they need to get the economy moving. So the public health measures, I think they helped us in the beginning of the outbreak. But I think as we move now, and I think we are seeing some window of opportunity that in most countries there is a decline, we need to have a balance to be able to relax some of these measures. I can tell you some other concerns that our surveys have discovered. There is an increase in gender-based violence. There is an increase in some countries in alcohol use. The impact on children's education is very severe. In some countries, we are seeing teenage pregnancies just because young girls are out of school. So we really need to be tracking all these things. And you as researchers, we expect you to be helping us to do tracking these data so that we have a comprehensive COVID response. So to sum up really, in the absence of proven therapeutic remedies or a vaccine, all countries must successfully suppress transmission. I think we have to look at a scenario where we say we live with the virus, but in a suppressed transmission burden. And that will require robust testing, isolation of cases, and identification of a quarantine of contacts. But I think we have to look at practicing hand hygiene. And then we need to balance the public health, social, and physical measures because the indirect causes of COVID are huge. And we really need to be tracking direct COVID mortality, but also we need to track indirect mortality, all-cause mortality, to be able to see what is the excess mortality we are seeing over this period in 2020 for some countries, because we anticipate that we are having people who are dying from COVID, but we are having people who are dying from other causes because they're not accessing services, people who are dying from non-communicable diseases, mothers who are not accessing maternal health or antenatal services. Finally, I think the COVID pandemic has changed our lives and the lives of societies and individuals across the world. We need to adjust to a new normal. But for us to do that, we need to mitigate the non-direct COVID pandemic effects. I thank you for your attention.
Fantastic, Ambrose. Thank you so much. What a fascinating overview of it. And it's so true what we're seeing in many parts of the world, especially the low-income countries, where actually the non-COVID effects are proving far more dangerous than some of COVID itself. But let's go across to Rajiv Tajadeen, who's speaking from Addis Ababa. And I hope, hello, Now, what is it? Good afternoon, I think, for you, Raji and Addis, who's head of public health. Head of Public Health Institutes and Research at CDC Africa. Thank you for joining us. Can you give us your perspective on the non-COVID effects of the pandemic?
All right. Thank you so much, Andrew. So will I be sharing my slide from my side or you do it from your side?
We have the slides from here. So just tell us when you have when you want the next slide and we'll move on.
Okay, perfect. So I think we can start right away. So thank you, Andrew, and the entire organizing committee. Thank you, Liverpool School of Tropical Medicine, for this opportunity to be part of this important conference that is looking at the gender aspect of public health in general. So today I'll be sharing with you the non-COVID effect of the COVID-19 pandemic from Africa CDC perspective. So next. So the outline of my presentation will be one to give you a sessional update as far as COVID-19 is concerned. Then I will touch base with the non-COVID effect of COVID-19 pandemic in Africa. Then I will move straight to coordination and collaboration with member states and the WHO. And I will also discuss a little bit about health workforce, how Africa CDC has supported our member states. Then I will conclude. Next. So as of today, we are looking at more than 27 million cases of COVID-19 globally, with over 880,000 deaths. Coming down to Africa, as of today, we are looking at 1.3 million cases with over 31,000 deaths. It's important to know that the African cases are just around 8% of the global total. And in terms of death, we are hovering around 5% of the global total. The good news here is that over 80% of the cases in Africa are actually covered. Now, if we unpack the Africa figure further, you will observe from the next slide that close to two-thirds of the continent's member states are actually recording less than 10,000 cases. Next. So this slide is actually showing us where we have come from. Next slide. Very good. Thank you. So this slide is actually showing us where we have come from in terms of the number of cases on the continent. Sometimes in July, Africa was averaging around 100 to 120,000 cases per week. Today, we are around 50,000 cases per week. Next. So Africa has been described as a continent with syndemics, simply meaning that we have a lot of endemic, we have epidemic cases, multiple epidemic going on at the same time. A typical example is DR Congo, where currently we have ongoing COVID-19 pandemic there. We also have measles outbreak, we have Ebola, we have the vaccine-derived paralytic poliomyelitis, everything happening at the same time. So this underscores the need for us in Africa to come up with what is the best way in terms of public health measure to address most of these issues at the same time. So looking at the impact of COVID-19 pandemic on the essential health services, which is one of the key non-COVID effects of this COVID-19 pandemic, you will agree with me that most of our member states have actually suffered disruption as far as their routine health services are concerned. And the current estimates suggest that more than 90% of our member states have experienced some sort of disruption. And most of these disruptions actually affected the routine care, elective services, critical care. All of these have been interrupted one way or the other. In terms of specifics and in terms of number, the most frequently disrupted services include routine immunization, such as the routine measles immunization, routine polio immunization. Our services have been affected 70% of the time, and facility-based services as actually been disrupted in 61% of cases. Looking at non-communicable diseases, this has been interrupted in about 69% of 69% of cases. Sexual and reproductive have been interrupted to the extent of around 68%. When you look at mental health, cancer diagnosis, malaria diagnosis and treatment, all these have been affected one way or the other. Next. All right. So one of the non-COVID effect of this pandemic is the effect on education. You will agree with me that education is one of those key social determinants of health. And this pandemic has created the largest disruption of education systems in history. In fact, close to $1.6 billion has been affected one way or the other. In Africa, more than 90% of our students have been affected. The pandemic has also raised fundamental concerns about human rights. It has exacerbated pre-existing education inequality by reducing the opportunities for many of the most vulnerable children and youth. Vulnerability in terms of children from poor homes, children from IDP, children from refugee camp, disabled children, girls alike, all these have been affected by one way or the other as far as due to this COVID-19 pandemic. An estimate suggests that close to 23.8 million additional children may actually drop out of school. So I think this is the time for us to begin to see how can we mitigate some of these non-COVID effects. Other aspects of our social services that have been affected include things like nutrition. For some kids, the only opportunity for them to have nutritious food is when they go to school. So these services is no longer there. And for some parents, their place of work is actually the school environment. Again, most of these people have actually been put out of work. And of course, as Ambrose clearly mentioned, we are seeing increased risk of violence against women and girls. So the impact of this non-COVID effect, is likely to extend beyond this generation, and is also likely to erase decades of progress that has been made so far. Next. So part of this non-COVID effect, again, we have seen a lot of countries putting in place all sort of travel and border restrictions. We have seen closure of businesses, closure of schools, and so on and so forth. And for a continent whereby more than 70% of the populace rely solely on informal sector to earn their livelihood, you agree with me that this is something that cannot continue definitely. So this has led to a lot of socio-economic impact as far as the common man in Africa is concerned. And what have we done in terms of responding to some of non-COVID effects? We've put in place or put out there a number of guidance and documents to support our member states in how they should mitigate some of the negative consequences of most of these measures that have been put in place to contain the COVID-19 pandemic. So one of these is a continuation of essential health services guidance and document, which clearly spell out the need for member states to come up with a protocol that will govern delivery of essential health services, to put in place a monitoring mechanism, that will look at service delivery, look at service utilization, and look at the gaps and how best to address some of these gaps. And of course, we continue to emphasize the need for member states to make sure that for every opportunity to talk about COVID-19 pandemic, they should also talk about the fact that the essential services, the critical services, the routine services are still being offered by the different health institutions in the country. And we also advise member states to remove user fee so that this will not serve as a barrier for the populace to access some of these essential health services. And as we plan to recover from this COVID-19 pandemic, so there should be in place, how do we make sure that some of the gaps that have been created, some of the negative consequences as far as this COVID-19 pandemic is concerned, is going to be addressed as we open up our economy. The other aspect of the non-COVID effect is the mental health and the psychosocial issue. So in this regard, Africa CDC rolled out a guidance document that look at how best to address the mental health and provide the needed psychosocial support to the affected and the infected. So let me shift gear and talk a little bit about coordination and the collaboration with member states. The first case of COVID-19 was reported on the continent on the 14th of February. A week after this, CDC, in collaboration with WHO, were able to convey a meeting of ministers of health from the 55 member states. And this meeting actually emphasized on the need for coordination, collaboration, communication, and cooperation. And one other aspect of our coordination is we've been able to raise this response to the highest political level, and this is the AU, the African Union Bureau of Head of States and Government, who periodically meet to champion what Africa CDC, together with other partners, are doing as far as COVID-19 pandemic on the continent is concerned. Another political layer is that of the what we call the coordinating ministers. So for the coordinating ministers, we are looking at the ministers of health, ministers of transport, and ministers of finance to make sure that our approach is what we call a multi-sectoral and whole of government approach to this COVID-19 response. And this ministerial or the coordinating ministerial committee regularly meet to provide direction and provide as far as our COVID-19 response is concerned on the continent. We have also put in place a steering committee, which is co-chaired by the regional director of WHO Afro and the director of Africa CDC, to also make sure that we develop a continent-wide response strategy, to shape the way we respond to this pandemic on the continent. Under the steering committee, we have the different technical working groups that is like co-chaired by Africa CDC and representative from member states. So I think as far as coordination is concerned and collaboration, I think we have it well covered. Next. 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 Okay. All right. So when the ministers met a week after the first case was reported, one of the things that was endorsed at that meeting was the continental strategy. At the same time, a continental task force was also endorsed. And this strategy emphasized on three key pillars. One is that of prevention of transmission, prevention of death, and prevention of social harms. Next. So, we have also rolled out what we call partnership to accelerate COVID-19 testing on the continent. And again, this is aimed at bringing every member state together in such a way that in terms of key pillars of response to this COVID-19 is well coordinated and well, there is some element of collaboration as far as this is concerned. And in that aspect, we set out 4 key goals. One is to roll out testing, because you will all agree with me that one of the key areas where we had issues as far as the continent is concerned is issue of testing. In fact, people believe that it's because of non-availability of testing. That's why Africa is not seeing a lot of cases. So in early April, Africa CDC partnership with other key partners on the continent came up with this initiative. And the goals of this initiative is to roll out 10 million tests within 4 months. So I'm glad to inform you that we have long passed this 10 million target. And part of what this initiative actually set out to do is to support member states with 1 million community health workers. So that is still ongoing, to continue to build the capacity of our member state healthcare workforce so that they will be able to respond and effectively to COVID-19. And in order to make sure that all the medical supplies, are equitably available and affordable to member states, Africa CDs, as part of this initiative, also put in place a pooled procurement platform that will make sure that each and every member state have access to the necessary medical equipment and supplies that is needed for them to be able to respond to this COVID. So still talking of coordination and collaboration with our member state, we realized long before now that the most important game changer as far as this pandemic is concerned will be the availability of COVID-19 vaccine. So to be proactive, the leadership continent came up with a conference, that will raise awareness on the need for African member states to have equitable access and affordable access to this COVID-19 vaccine when it does become available. So that meeting was conveyed at the highest level. In that meeting, we have President Cyril Ramaphosa of South Africa. We have WHO Director General, the Regional Director, Africa CDC Commissioner, and so on and so forth. So these were all the key members that were in that meeting. Next. Right. So still part of coordination and collaboration. So Africa CDC put in place a COVID-19 vaccine development and access strategy. And the goal of this strategy is that of successful immunization of a critical mass of the African population with a safe and effective COVID-19 vaccine. Next. So for under this strategy, we have key goals. One, to accelerate African involvement in clinical trial and vaccine development. Two is to make sure that there is access to sufficient vaccine supply. And three is to make sure that the issue of logistics and distribution are adequately covered on the continent. Next. Again, as part of coordination and collaboration, 2 weeks ago, Africa CDC and the African Union launched a campaign called Saving Lives, Economies, and Livelihoods. And the key objective of this campaign is, one, how do we safely reopen our borders and make travel as safe as possible? Two, how do we safely open our economy and businesses? And three, how do we safely reopen our schools? Next. In terms of clinical trial, we also have a technical working group that is looking at this to ensure that each and every member state, it's able to benefit from whatever vaccine, therapeutics, or diagnosis that is going on. And we're also using this opportunity to build local capacity to ensure that there's appropriate transfer of technology to support our member states. Next. So what have we done to support the health workforce in Africa? We realized right from outset of this COVID-19 pandemic that member states are not at the same level as far as health workforce is concerned. We know that in terms of health workforce, the gap is so critical that we just have to support some of these member states. So what we did was to mobilize workforce through the African Volunteer Health Corps platform to support some member states in need. So today we are happy to say that we have supported 21 member states with senior epidemiologists, and we have supported about 28 member states with community health workers. And we are not only throwing out those figures there, we are also supporting them with the necessary capacity in the different key response pillars as far as this COVID-19 pandemic is concerned. Next. So in terms of the key pillars, we are looking at surveillance, we are looking at clinical care, we are looking at infection prevention and control, we are looking at lab, risk communication and community engagement, and of course, last but not the least, we are also looking at supply chain management. Next. So I would like to conclude by saying that the COVID-19 pandemic has revealed a lot of cracks in our health systems. It also reminded us of the need for new strategies to improve healthcare provision during pandemics and beyond. And as a continent, we need to be better prepared for emergencies, but also keep investing in health systems and systems for health that can fully respond to people's needs throughout the life course. And we must see global health security and universal health coverage as two sides of the same coin. And for our member state, that coin is the National Public Health Institute. I thank you for your attention.
Brilliant. Thank you so much, Taj, for that overview from CDC. That's fascinating, and it brings up a whole hundreds of questions that we're all wanting to ask, and there's questions all coming up online. Unfortunately, one of the problems with global health online conferences is that people are signing into other sessions which are due to start in here in 5 minutes. And so actually, I'm afraid we don't have any time for questions. What we do have is an online platform whereby people can ask questions. And if Taj and Ambrose, if you could both have a look at the questions online and provide your answers for them. Because there are serious questions about data management and about how you collect accurate data, both on whole populations, so that we're not just concentrating on COVID, and so that we get accurate coronavirus infective data as well. But I'm afraid we need to call it a day there. Thank you so much to both of you for joining us from Addis and from Pretoria. I'm glad that the links all worked. The next session starts in about 4 minutes' time. So that gives people a brief chance now to either stretch their legs, maybe listen to Nazim, who's our musician, who's part of the conference here. There's some yoga, there's posters, which if you go onto the app or onto the website, you'll find from the homepage. There's also some soapbox presentations. And then we start again in 4 minutes' time. What you'll need to do is, once this finishes, click back onto the live agenda, look on the live agenda and click onto the next session. It won't feed through automatically from this session. And then just to remind you, those of you who are looking to pick up Annie Portella's discussion from earlier, in fact, she's now at 12:50. This is British summertime, so this is GMT +1. So this is in exactly 1 hour's time. Annie Portella from WHO will be talking on respectful maternal and newborn care, a time for action. So thank you for joining us. We'll see you back in a few minutes.
Thanks, Andrew. Thank you, Andrew.
Good morning, everyone. As we continue our session in this exciting conference, we're still on the theme of implementation science. And in this panel, I'll be facilitating. We're going to discuss using implementation science to enhance global health. My name is Dr. Charles Ame. I'm a senior clinical lecturer here at the School of Tropical Medicine, and it's my pleasure to facilitate this panel. We have a very rich panel with several decades of experience in implementation science and research. I'll make brief introductions to the panel. Sitting with me here is Professor Sally Theobald. She doesn't need any special introduction. For those of you who missed the excellent keynote address this morning, it's on the app, it's online, you can still go back and watch it. But Sally is a professor of international public health and social sciences. She has extensive experience of collaborative research focusing on health systems in low resource settings. Sally, you're welcome.
Thank you.
Yes. My other panelist is online. She is Professor Imelda Bates. She's professor in clinical tropical hematology. She's the head of the Center for Capacity Research, honorary consultant hematologist, Royal Liverpool Hospital. She has several decades of experience, building capacity of researchers in low income settings. So she's going to be talking to us about, a systematic approach to doing this during this session. Imelda, you're welcome.
Thank you.
My third panelist is Annie Potella. Annie, glad to have you online. We had some technical glitch this morning. She couldn't join us, but right after this panel, she will give her keynote. So Annie is a senior technical officer based at the World Health Organization in Geneva. She has worked with governmental and non-governmental organizations for over 20 years in designing and implementing programs in maternal and newborn health. Annie, you're welcome. The last but not the least panelist is Professor Jane Sandel, CBE. She's a professor of social science and women's health, Department of Women and Children's Health, School of Life course at King's College, London. She's a senior NIHR investigator. She's a lead maternal health systems and implementation research group. Thank you for accepting to speak. You're welcome. So I'm going to hand over now to Jane, and Jane will give us her first presentation. She'll be discussing using implementation science to enhance global health programs, complex interventions in global health settings. Jane, as you want us to move your slides, you just say next.
Thank you. And thank you for asking me to talk. I would also like to say I'm a midwife as well. So I combine my clinical experience with my implementation research. I can't actually see the slides on my screen. So perfect. Thank you. Next slide, please. So you will have seen the same message earlier this morning, but the implementation challenge is that we have trials that show that implementations work in a trial setting, but then we fail to scale up, and it's hard to transfer from one setting to another because of differences in context. So how can implementation research, when it's combined with complex intervention research, inform scale up? Next slide, please. I am going to give you a brief example of what's called an effectiveness implementation hybrid trial. In effect, what we did was test the effect of the intervention as well as the data on implementation. Next slide, please. Why is it necessary? We're trying to understand the mechanism of the intervention. so that we will know better if it will produce the same outcomes in new contexts, so we can better understand why there was no effect and how it benefits the target population. Next slide, please. Our work is drawing on the MRC guidance for developing and evaluating complex intervention, and I've added to this slide where implementation science contributes all the way through of development and testing and scale up of interventions, starting with doing theory and change and logic models in the development, with testing implementation strategies and doing process evaluation, to doing an implementation evaluation in a full-scale trial. Next. There is detailed guidance from the MRC on how to do a process evaluation. This is complicated and draws on how we can talk about impact of context and mechanism of change. And I'm going to talk about how we drew on this guidance in a pragmatic trial. Next slide, please. So I'm going to talk about lessons learned from doing an implementation assessment alongside a pragmatic trial. It's called the Cradle 3 trial. It was funded by the MRC and Gates, and it was testing the Cradle vital sign device plus educational support in 8 low-income countries in all settings with all health workers, with the aim of reducing maternal mortality and morbidity. I've put the implementation strategies up there, and there's much more detail in the 2 papers that I've referenced. Next. So the aim of our implementation evaluation, and remember this is a pragmatic trial, so we didn't want to put a huge amount of resource to support implementation in the trial because that wasn't going to happen in the real world. So we wanted to describe the implementation, and we wanted to look at some of the implementation outcomes to see whether that may explain the differences of effect in the different sites in this step wedge trial. Next. I've put here our model of what we were looking at. So was it delivered as planned? Did it reach the women who we hoped it would reach? How much was delivered? Was it adapted? And could it be sustained? And we wanted to look at impact and unexpected pathways and acceptability. The main outcomes of the trial I've put up on the slide here. Next. This is a complicated slide. It's for you to look at afterwards, but I wanted to give you an idea of what we were able to look at, looking at context, how we measured fidelity, how we measured reach, and how we measured adoption. Next slide, please. So in terms of fidelity, we trained just under 2,800 health workers. Sorry, I've lost my main screen. But the range was large, from 16% in Kampala to nearly 90% in Malawi. We delivered the key content, and the majority of participants reported the training was adequate. Next. In terms of adoption, I've put some data here that we collected, and again, a huge variability in whether the sites were able to adopt the Cradle device and some of the barriers to adoption. in terms of mistrust of using a new device, and the different results you can get from blood pressure monitoring machines. It was really important to have the active support of the Cradle champions on site. Next. In terms of reach, we managed to have a significant increase in women who received blood pressure measurements after the intervention, better availability of the equipment on the site, and junior staff and students were more confident in taking the measurement. Next. So the results are in the two papers I've given you reference to. There's huge variability in effectiveness by site, and the overall result when you took confounders into account was no effect. And of course, with a step wedge trial in each site, what you have is a before and after measurement. Next slide, please. So what did we learn? We learned it was possible to do a hybrid effectiveness trial in a pragmatic way in low resource settings, that you could evaluate process measures, that the ones we chose were appropriate, but it is challenging to describe context and mechanism in a more sophisticated way that's described in the MRC process evaluation framework. And there's very little guidance for how you combine implementation science in the pathway of developing a complex intervention. Final slide, please. So what do we need to know? We need to know that we need to have a very good description of what is being implemented, who, what, when, where, how, what the strategy is, what the setting and the context is, whether the implementation outcome variables are appropriate for the study and the site, and how we consider secular changes over time. So for either any research assessing complex interventions, trials, or whatever design, these are really important questions. Next slide, please. I'd like to acknowledge the Cradle team who are here, and the chief investigator and the lead of the trial, who's the lead author on the publications. And there is a reference list that I've added onto the presentation. So thank you.
For that excellent presentation. I just want to remind conference delegates that you can put in questions through the app for Jane. We will take the questions after Imelda gives her presentation, which is titled A Systematic Approach to Strengthening Capacity for Implementation. So please, over the next few minutes, please put in questions that will help us get discussion going in this panel. Imelda, over to you.
Thank you very much, Charles. Can you hear me okay? So I'm going to discuss a systematic approach for how to strengthen capacity for implementation research. And it follows on from Jane's very eloquent description of how to use implementation research within a complex project. So can I have slide 2, please? So why is it important to strengthen capacity for implementation research? And I hope that Jane's presentation has illustrated why it's really important to have enough people that can do high quality implementation research. A lack of implementation research capacity is a major bottleneck in enabling people to turn research findings into actions. And as a result, it hinders socioeconomic development if you don't have enough capacity to do implementation research. Also, funders are increasingly investing their money in strengthening capacity because they recognise there's a direct link between implementation research capacity and development. But they need evidence of where this money's going and how it's being spent and whether it's been effective. As you'll all know, those people that write proposals, in many proposals, you are required to write something about capacity strengthening and to show systematically how you've achieved impact. Can I have the next slide, please? So just to explain a little bit about how we have some legitimacy within our centre to be able to talk about strengthening capacity for research. So we do a lot of practical projects where we do implementation research, but we also do a lot of theoretical studies, and we produce a lot of evidence and concepts around how to do better capacity strengthening for research across the whole research system. So just click again, the next box should come. So we generate transferable evidence about how to do, track and measure the impact of research capacity strengthening programs. So you can see that that's helpful to researchers and implementers and also to funders. Click again, the third box should come. Thank you. And therefore we do collaborate very closely with funders and the implementers, and we tend to sit between the funders and the people on the ground. Slide 4, please. So I just want to stress that the principles that we use for strengthening capacity for research can apply to any research topic. The principles I'm going to talk about are not restricted to maternal health, although we have used them for maternal health. I'm a haematologist, so a lot of my maternal health work is around anemia and blood transfusion. But we've also, for example, used the same principles on soil science and termite hills and nanotechnology for solar panels. So it can apply to anything. Next slide, please. So how do we take a systematic approach to strengthening capacity for implementation research? So the first important principle is that we have to think about the whole research system. When people think about capacity strengthening, they often think about training researchers, but it's much, much broader than that. And training is a minor component, actually, of all the other inputs that need to go into the system to strengthen a research system. When we think about designing capacity strengthening, we think about it under two concepts. It's a very complex subject, and so for me and the rest of our team, we've had to turn it into some simple ideas that we can deal with and that we can use across different projects. So there are two simple concepts. One is about a prism, which I will talk about in a second, and then we take a 5-step approach. We adapt it sometimes, but we always think about these 5 steps. So if you click again, you'll get the prism. So if you click twice, you'll have a circle around the whole system. So the research system comprises the individuals, the institutions in which they work, and around this are things like research culture and the research infrastructure that makes a conducive environment for those individuals to do research. And then at the bigger level, we have something called environmental or societal level. And this refers to national policies, international collaborations, uptake of research findings. So those 3 levels constitute the whole research system. If you click twice again, and you see that the process of strengthening capacity, it's not really a linear process. There are lots of reflections and looking back and learning and redesigning. But overall, you start with some planning, then you do try something out, experiment a bit, but build in a lot of learning. And then when you find that something works, you can expand it and consolidate. Next slide, please. So there's a 5-stage process that we always follow if we're designing a capacity strengthening programme. And although we may not apply all of these, we may not have money or time to do that, we always think about them. And I think Jane stressed how much it is needed to do the planning up front. It's really important to plan properly. And one of the things that we find is often missed out is that people just don't define the goal of where they want to go. Where are they trying to get to with their capacity strengthening project? Do they want their centre to become a centre of excellence for maternal health? Or are they trying to turn it into a training centre for something? If you don't define the goal of where you want to go, then you don't know if you're going to get there and you can't map out a pathway. So I'm not going to go through all these steps in detail, but just to say that having defined the goal, which is difficult, it requires all the stakeholders on board to get a goal defined that they all buy into. And then once you've got the goal, you have to look through the literature, talk to everyone and try and describe what the optimal capacity is if you want to achieve that goal. And that means across the whole research system, not just training. And then once you've worked out what the optimal capacity is, you can use that as a sort of benchmark or checklist against which to look at what capacity is already existing. And then you can very systematically identify any gaps. And obviously, once you've done that, then you get into a normal sort of action planning cycle where you try and fill the gaps in capacity, see if you've filled them, look for other gaps and continue on like that until you finally reached your goal. Next slide, please. So some of the things that we've learned through being involved in many projects, we've currently got 14 projects, 70 countries involved, many consortia, and we've learned a lot by being able to pool information across all of these projects. So some of the lessons that we've learned that it's worth thinking about very early on if you want to sustain any of your implementation research capacity is that early on you need to engage all stakeholders. I can't stress enough how important it is to get everybody on board, that everybody buys into plans for scale up and you think about them early and how you're going to influence policies and get your research taken up. I know that's something that you actually do near the end of a project, but if you don't plan at the beginning, it's really hard to build it in later. And include all the way through these quality assessments and learning so that everybody understands why changes are being made, why you're progressing or why you're not progressing. At mid-time in the project, by that level of time, you should be able to see that some of the resources that you've got are being improved, people are getting their skills, you might have improved the infrastructure in an institution, and the activity should be being taken up by an institution or by a programme so that they're not dropped when the project comes to an end. And at the mid stage, there should also be some evidence of innovation and expansion so that you're not just working within the confines of the project, but that you're thinking outside the box and trying to bring on, for example, new partners. And then towards the end of a capacity strengthening project, you would really expect to see that there had been some investment in core activities and that was going to continue on. So there'd been additional funding to support some of the core activities that aren't normally funded through projects, and that a lot of the decision-making management, as much as possible, was led by local partners who understand the context and need to have ownership in the long term. So there are three things that almost everybody struggles with when they're trying to sustain any sort of change, and particularly change in research systems. There's often a very high turnover of staff and stakeholders, so you need to keep going back to them to make sure they're all engaged. Trying to embed changes within existing systems, because that's the only way they're going to sustain, is very hard and needs a lot of thought and effort. And obviously securing funding and influencing policy development are also very difficult and need to be thought about all the way through. Next slide. So this is my last slide. I'll just leave you to read those comments from some of the participants that have been involved in some of our projects about building implementation research capacity. Thank you.
So we've listened to two very rich complementary presentations, which have really outlined, the difficulties in conducting implementation research, even with very comprehensive frameworks and guidelines that are available usually through funders. We've also heard about an effectiveness implementation hybrid trial, and some of the difficulties and challenges when you conduct such trials, especially in resource-poor settings. A lot has been said throughout today about the need to get stakeholders on board early, engage them early, not just at the end. There's a big question of what happens once the project ends. So once all the project staff have packed the things and gone, and you come back in 3 months' time, then its history is all over. So, but how do we sustain this? It's only by really engaging, with partners on the ground quite early. So, some very interesting threads that have come through both presentations. Let me just turn to Annie. What do you think is the role of underserved populations, women and communities in the design of health programs and services?
Let me unmute. Thank you. And just let me start by saying thanks to Jane and Imelda. I really felt they got us off to a good start. And in your summary, Charles, you captured, again, to me, it's impossible to think about implementation research if we're truly trying to develop a model for implementation, if we are not working closely with, and I'm going to add, health providers, women, communities, local authorities, because one, in order to design and develop that local model and integrate your proposed intervention, either simple or complex, into the system, it can only be done through consultation and through a design process that allows these inputs and allows the ongoing dialogue and advice to, again, make sure the implementation is integrated. Otherwise, we do risk that it is more of a research project. And so, it shouldn't be because the research part closes that the implementation stops. Now, the research part does give that push, if you will, to the implementation part, because of that maybe more intense monitoring that happens, the more follow-up, and as Jane was saying, that eye to the quality of implementation. But in terms of their role, it's just so key, not only for design, but throughout the life of an implementation research project. Over.
Thread coming through there. One of the things in Jane's presentation, she talked about barriers to using the new device, the Cradle device, in that study. And she emphasized the role of the Cradle champions. And I know in your presentation, Sally, this morning, you talked about the importance of local implementation teams. Mm-hmm. So how important are those teams to ensuring sustainability and acceptance of research findings?
Sure. So I think that having implementation research teams that come together, come from different perspectives, it lies at the heart of a lot of successful implementation research processes. And we talked about the importance of bringing different perspectives and different positionalities to bear in implementation research. And Annie's just highlighted the importance of communities themselves, women, children, others, as being part of that process. So yes, implementation research teams, collaboration, co-production, partnership, trust, all those issues we talked about this morning, I think are critical and are part and parcel of co-production. We know that people working, living, breathing in health systems have that tacit experiential knowledge. And it was really, Jane, I really enjoyed your presentation and learning about a hybrid effectiveness pragmatic trial. And in the slides I gave this morning, in terms of the spectrum of implementation research, it was a lovely example of implementation research embedded within that pragmatic trial, and also of learning across multiple contexts and it would be really nice to learn more about those Cradle champions and their role and how that differed, and with respect to sustainability, what happens after the trial? Does that role still exist? Is it still required? Or is this learning embedded within the system already? I had another comment. I don't know if I can make it.
Go on.
Just to link with Imelda's presentation and the projects I talked about this morning, many of those collaborate and have benefited from expertise for the Centre for Capacity Research. And I really like the holistic prism, looking at the research ecosystem as a whole. And it really reminds me of health systems as complex adaptive systems. And that's what we're doing in implementation research, right? Thinking about health systems as a whole, how do you build capacity within and across all the actors that are part of that ecosystem? So holistic learning at those multiple levels in terms of environmental, social, institution, and individual. Thanks.
Absolutely. Thanks, Sally. Thanks for that. So I think one of the things we have really talked about today is, the changing context. And in Sally's earlier presentation, and in the presentation that followed from colleagues from the WHO, from Africa CDC, I mean, these are changing times. A lot of things are constantly changing on the ground. So without good engagement with local partners, we cannot learn from this process and we cannot adapt in such a way that we have a fine balance between research and then bringing about evidence-based changes. One of the questions that has come through is how relevant is implementation science to health systems strengthening? I wonder which member of the panel wants to take this one on. Jane, do you want to have a go? How relevant is implementation science to health systems strengthening?
Well, I think it's relevant to all research questions, to be honest. I really don't think you can do good health system strengthening research without involving those different approaches and methodologies and tools that implementation science can offer.
Thank you. Annie, do you have anything to add?
Yeah, I think all of us will kind of make a similar comment, is that, we just learn more and more that a lot of the recommendations that come out, a lot of these best practice, a lot of the key interventions, all are so linked to the health system and the context. And so, if we don't have these methods of learning, either through implementation research or embedded practices of learning, I find a lot of the times the health system strengthening can remain either vertical or theoretical. So it's only through that process of embedding it, of trial and error, of learning, and of a broader engagement with a group, of different, as Sally said, different constituencies who can input and help that. I mean, I just feel the question is almost, I want to just say a simple yes, of course. Yeah, it is really, so linked.
Okay, thank you, Annie. So one question is about, what are the additional challenges to implementation science or research uptake in informal, fragile settings, informal urban settings? Are there additional specific challenges? Sally?
So I think what's key in implementation research is that context matters.
Yeah.
And there are a whole multiplicity of contexts that we work with in implementation research. So I gave the example this morning of Rebuild for Resilience, which specifically focuses on fragile and shock-prone contexts, and also of Arise, which specifically focuses on informal urban contexts. And I think that the principles in those contexts are similar to others, right? We have to find the most appropriate people to engage with in those implementation research teams to build trust, to support the principles of co-production. And we know that in fragile contexts, that can be complex. Post-crisis, post-war, during a pandemic, there may be multiple players involved. There will be multiple players involved. It can be fluid, it can be changing, it can be complex. So it's what is the best way to build those partnerships in a changing and evolving system. And that's going to depend on the issue, on the context, on the type of fragility. And it's about partnerships with embedded people and institutions that can shape and bring positive change. In Arise, I talked about the different partnerships, and we're really privileged to collaborate with Slum and Shack Dwellers International, a federation of people living and working, and NGOs and others in slums and informal contexts across 38 different countries. So really understanding and being part of the lived realities in those contexts, those are groups that understand the nuance, understand the ways vulnerabilities play out, understand the challenges to accessing health and how COVID is overlaying that and amplifying new vulnerabilities. So that to us has been an amazing partnership. So what I'm trying to say, probably not very eloquently, is the context will shape the partnerships. And we need to build partnerships for change, whether that's an urban context, whether that's a fragile context, whether that is a hospital context. It's about working to nurture trusting partnerships for change and the co-production of knowledge.
Absolutely. So I think one thing that comes out consistently is the need to do adequate planning and starting early, because if you don't understand the context from the beginning, you can't identify the right partners. And in Imelda's presentation, she talked about some of the challenges around sustainability and getting things to change, the high staff turnover. So we need to build those relationships at institutional level, identify the right key players to help us understand the context and bring about lasting, sustainable change. In the last few minutes we have, I just wonder what will be the advice of the panel. You have a lot of young researchers, people going new into implementation science. What are the things they should look out for when they are making grant applications? What are those things they need to embed within those applications that will help them get success? And what are the key take-home messages in terms of being a successful implementation science researcher? So maybe we'll just go around. We can start with Imelda.
I would just pick up, Charles, some of the things that you just said. I think if you're starting off in the field, you should plan your capacity strengthening for research with exactly the same rigor and thought that you would apply to any other research project. If you want to do it properly, you need to plan early, you need to know what your pathway is to achieving success, and you need to understand how you're going to measure and show success. And I think if you have to write about capacity strengthening in a grant application, you need to do it in a very systematic and rigorous way like that. I think if your funders and you're funding capacity strengthening for research, whatever research, but particularly implementation research, that you need to be thinking about meaningful indicators. if you really want it to happen, to be sustained, to be impactful, then you have to be serious about having indicators, evaluating the proposals with regard to the rigour with which capacity strengthening plans are written in there, and also monitoring progress in strengthening research capacity across all those levels. In general, it's done in a very perfunctory way, and I think researchers know that's how it's done in terms of evaluating their projects, and therefore they don't invest the time and energy that's needed to make it impactful and sustainable. And I think, again, picking up what Sally said and everyone else has said, that context is really important. So I think being flexible and responsive and proactively building in learning at every stage and using that learning to improve the programme and make sure you don't make the same mistakes again is also critical. Thank you.
Thank you, Melda. So some fantastic words of wisdom there. I mean, we cannot underscore the importance of early planning. You need rigor, a systematic approach. You need to build a system of learning and documenting, what has worked well, what has not worked well. How do you measure success in terms of process and impact? This needs to be thought through very earlier on. And then, something that came out from Melda's presentation was, the need to be able to identify those research capacity needs of the local team. This is something that you have to do to build into, the grant applications and for success. Jane, any final words of wisdom for, our young researchers?
Yeah, very practical, very practical.
Yes.
So one, get your team right. Very often there's a lot of inequity between high income partners and partners from low income settings. And many times, voices that should be on the collaborating partnership are not there, even though the research is about the work they do. And I give midwives as an example that are often missing from grant applications. Give cognizance to the people from the setting where you're doing the research. They are the experts. They know what the problems are. The problem should arise from low income partners and settings. With intervention research, describe what the intervention is and describe how it's going to be delivered. And there are reporting templates for how you do that very simply. Describe your implementation strategy and give some kind of indication of how you think it's going to work. Open the black box. So someone who is reading your application can think, okay, yes, I can see if they do that, then that will happen, and then that would have an impact on those process and outcome measures that are in the application. I can't emphasize how important doing theory of change early with all the stakeholders and community partners is to get this right, and to doing a logic model. I think they're fantastic for getting the team around the table and all the key stakeholders as to what you're planning is the right thing and how you think it works and how you're going to measure that so everyone's on the same page.
Thank you very much, Jane. So again, the issue of adequate planning, and then, as all the speakers have emphasized, the issue of equity in partnership, and also recognizing the value of those stakeholders on the ground who are the experts in, their problem, and they know the solutions, they know, the practicalities in getting around things. So engaging them early, she talked about opening the black box. We need to anticipate what the problems are, develop a very good theory of change with all the relevant partners, so you can track progress and success. I like the way Jane has really advocated for midwives. In this International Year of Midwives, it is quite important that, we have equity, within that team. As we round up this session now, I just want to say big thanks to all the panelists. Thank you, Jane, Sally. We have pulled you out from your busy schedule today. We've had you for more than half a day. We've been back and forth, troubling all the panelists with the presentations, getting ready for this. And I think it was a fantastic panel and lots of lessons to learn. I just want to the participants to know that the video will be available online for some time. And you can always access this content, and the slides are there for you to look at, a lot of frameworks and references that have been put through. Immediately after this, we're going to have the keynote by Annie, which we missed out in the morning. But in order to access that content, you will have to come out of this and then click on the link through the app for that keynote presentation by Annie Potella. So once more, I want to thank all the panelists, and I encourage you to continue with the rest of the conference. We still have a lot of packed evidence and experience to share throughout this conference. Thank you. Those long summers, we played water fights, stayed up at night, and dreamed of ways through the world. I still remember the first time I kissed you, the look on your face as I grazed your lips with my lips. Our worlds collided. Those were the days when everything was possible. Our dreams were alive, we had a fire inside. Those were the days. Those were the days. I'll always remember that cold night you told me we're not two, but we're gonna be three. In 8 months we'll be a family. Those were the days when everything was possible. Our dreams were alive, we had a fire inside. Those were the days. Right from the beginning, I knew that I loved you. Girl, we've got something amazing. It's just me and you.
Right, hello everyone again. It's been a hectic morning here. We've had some really exciting presentations, and I've had lots of messages from nurses and midwives around the world saying how excited they are to be part of this conference. So that's fantastic. So Annie, I'd like to introduce you. I know some of the speakers will already have listened to you, but some may not have. So Annie Potella is going to give the next speech. It's one of the keynote speeches. She's a senior technical officer at WHO in Geneva and has over 20 years experience in working in maternal and newborn health, with particular focus on access of care for underserved populations and women, and community participation in the design of health programmes, which we've spoken about already this morning when we were talking about implementation science. Annie, we're really looking forward to your presentation, so over to you.
Thank you, Terry. My apologies to everyone for the hiccups this morning, but I do want to thank the teamwork, the organizers of the conference who handled everything exceptionally well, maintained Zen, and just talked me through it and got me here now. So apologies to everyone, and I look forward to this moment. My job was a little different. I understood right now I'm not supposed to talk about implementation research, but rather kind of the broad overview of respectful maternal and newborn care. And then I wanted to do that as a WHO team and a team with some others who are really, working a lot on this. So the first part of the presentation will have Hediye Mertaş and Özge Tunçalp, who have a recorded presentation, and they'll give you some of the background and the conceptual history of respectful maternal care movement. And then we'll go over to Emma Sachs, who is live with us, and she'll talk a little bit about the integration of newborn, making sure newborn is integrated when we talk about respectful maternity care. And then finally, I'll just take us through some of the implementation challenges that we have seen very, very briefly. And I hope that I leave you with those implementation challenges. And as you reflect on implementation research over these next sessions and tomorrow, you can think about ways you would address them as you design future research. So I think we're ready to start with the slides.